Mr. Chairman, Co-Chairman, my dear colleagues, uh, I will present today the topic of uterine arteriovenous malformation. We will talk about the definition, the epidemiology, etiology, clinical presentation, histopathology and diagnostic imaging management, complications, and how to follow up the patient after treatment, and lastly, conclusion. UAVM was firstly described by Duberly and Lubuet in 1926. It is defined as unnatural connections among uterine arteries and veins, which usually occur during the fertile age. It is a dilatation of vessels in alternating space deep inside the myometrium with the absence of capillary vessels, leading to direct flow of the blood from the arterial system directly toward the venous system with no capillary connection. It can be categorized as high flow vascular malformation and signified by high pressure gradient across the arterial and venous system that enables a high vascular flow through the nidus. Central nidus is defined as tangle of vessels in which often multiple arteries and veins converge. It is classified as congenital or acquired, and the acquired type is the commonest type. Currently, it can be classified according to YACS AVM classification system based on angiography technique. The congenital one is the abnormality in the embryonic stage with multiple connections. It may be solitary in the uterus or may be present elsewhere in the body, like brain arteriovenous malformation. The acquired type results from trauma to the uterus after surgical intervention or infection or even malignancy. This is the YAC classification system. It is classified into 4 types. Type 1, the red color is the artery, the blue color is the vein, and the purple color is the mixed arterial and venous. This is direct AVF, this is the type 1. Type 2A, this is the nidus, connection of arteries and the veins, and then the venous side. Type 2B, the nidus is shunting to aneurysm before the going to the drainage vein. Type 3A, the aneurysm, the nidus is connected to the aneurysm and then one vein draining. Type 3B, multiple outflow vein, and this is the type 4 tissue infiltrative AVM. This is the YACS classification system of AVM. How about the epidemiology of uterine arteriovenous malformation? The true incidence and the prevalence of UAVM are difficult. Why? Because of their scarcity. Furthermore, many cases was diagnosed as dysfunctional uterine bleeding and receive medical treatment, so it's missed in the prevalence. There is little information about the frequency, but the overall frequency 1 to 2% of all genital and intraperitoneal hemorrhage. The use of ultrasound have been overdiagnosed the UAVM, and it has been suggested that lesion detected with hypervascular and turbulent flow be designated as uterine vascular malformation. The etiology of uterine vascular malformation, as I mentioned before, congenital type, it is resulting from arrest or failure of embryonic differentiation in the primitive capillary plexus. The congenital type have multiple feeding arteries, central nidus, and numerous large drainage veins. There is a mutation in the RASA1 gene on the long arm of chromosome number 5, which is responsible for the capillary development. The acquired type, as I mentioned previously, it is a result from prior uterine intervention, surgical intervention in the uterus, like therapeutic abortion, curettage, or cesarean section. It can be associated with infection, retained product of conception, gestational trophoblastic diseases, malignancy in the cervix or in the endometrium. What is the clinical presentation of UAVM? Bleeding. Vaginal bleeding is the most common presentation of UAVM. It might be menorrhagia, metrorrhagia, or menometrorrhagia and postcoital bleeding. Vaginal bleeding in acquired UAVM usually occurs in women who are at childbearing age, postpartum, or have previous uterine interventions. Therefore, medical history is important to help the diagnosis of AVM. The physical examination in a patient with UAVM, you may palpate an abnormally dilated vessel in the vagina. You may palpate a bulky pulsatile uterus or pulsatile mass in the adnexal region. The histopathology after doing hysterectomy for cases of UAVM, common pathological features include presence of multiple vascular fibrous nodules, including veins and arteries. They appear diffusely to the entire uterine wall from the serosa to the endometrium, including all the uterine wall. The arrangement of vascular structure is branched, plicated, with diversified size and many fibrous nodules. How to diagnose UAVM? By diagnostic imaging. Firstly, by grayscale ultrasound or Doppler ultrasound, then CT, computed tomography, MRI, or digital subtraction angiography. These methods of imaging play a very important role in diagnosis, treatment, and follow-up of these cases. Each imaging modality has its own advantage and disadvantage. Choosing the appropriate technique depends on the clinical situation and the patient comorbidity. In some cases, single imaging technique is insufficient, and we may need more than one technique to coordinate many imaging tools to ensure an accurate diagnosis. Firstly, grayscale ultrasound. This technique indicates subtle and non-specific images that make it difficult to diagnose UAVM. The most common finding is subtle myometrial heterogeneity or small anechoic spaces in the myometrium. Finding of mixed echogenic mass in the uterus are common and may be mistaken for retained product of conception. Color Doppler ultrasound. Color Doppler reveal a tangle of vessels with the multidirectional high velocity flow, making a color of mosaic pattern. They also show an increased vascularity area in the uterine muscle and a distinct group of vessels coursing the myometrium from the arcuate vessels running perpendicular to the endometrium. Similar features can also be seen in retained product of conception, placental polyp, gestational trophoblastic disease, and vascular endometrial neoplasm. Spectral Doppler ultrasound image show high velocity and low resistance flow. It is often difficult to differentiate the venous and arterial waveform. This image shows the grayscale ultrasound with multiple anechoic spaces. This Doppler ultrasound with mosaic pattern, and this spectral ultrasound show high velocity and low pressure flow. The computed tomography scan shows that UAVM has the same density as muscle, but high density than fat. Spiral and multi-slice CT scan provide fast and high-resolution image that allow for extremely precise measurement, mapping of feeding vessels and drainage circuits. However, it has disadvantage of radioactive nature and the minimal provision of flow velocity information, so its role is limited to emergency cases or when MRI is unclear or complementary to the next interventional or surgical planning. This is CT view showing the small arrowhead showing the vessels and the large arrow showing the nidus or the aneurysm. MRI is a non-invasive and valuable technique that provides good compatibility with digital subtraction angiography to support the diagnosis and treatment of UAVM. MRI usually reveal an abnormal tangle of blood vessels with early contrast enhancement. Advanced technique of high resolution bright and black blood sequential show MRA, magnetic resonance angiography, and there is 3D MRA, which is more diagnostic than natural MRA. And this is the MRA, magnetic resonance angiography. The digital subtraction angiography is the gold standard for diagnosis and intervention of these cases. There have been several studies in the literature regarding creating 4D DSA images from 3D DSA image obtained with time resolution. This technique gives the reader a better ability to identify characteristics of the lesion than 3D. With 4D DSA, planning stage of intervention can be simplified. This is the subdigital traction angiography, and this is 3D one, and this is the angiography after embolization. How to manage these cases? Once accurate diagnosis of UAVM is given, the management principle depends on the hemodynamic status of the patient, the degree of bleeding, the patient age, and the desire for fertility. In the case of unstable hemodynamic, intravenous fluid resuscitation must be initiated, as well as blood product, and the Foley's catheter can be worked to stem the bleeding in the situation of life-threatening hemorrhage. Patient with minor bleeding and stable hemodynamic status, conservative treatment. Many of these patients will have no symptoms, suggesting that microlesion UAVM resolves spontaneously on its own. Angiography and embolization should be considered in patients presenting with anemia, recurrent bleeding, or hemodynamic instability. The conservative treatment, different medications have been tried to treat UAVM, like methyl-ergonovine malate for 1 year, danazol therapy, combined oral contraceptive pills, and even GnRH agonist. Endovascular treatment, uterine artery embolization, can be performed in patients who are hemodynamically unstable and require blood transfusion. Embolization is preferred over open surgery as the initial approach due to its benign, minimally invasive, and fertility preserving. The most commonly used embolic agent was polyvinyl alcohol particle. Other embolic agents can be used like microcoils, like gel foams, sponge, and etc. In general, the treatment of UAVM embolization should be based on the YACS classification system. According to the type of YAC classification system, we can use the embolic material and the technique for embolization. Current technique for intravascular diagnosis and treatment often use DSA, digital subtraction angiography, to pass microcatheter from the femoral artery up to UAVM lesions, and then inject contrast material for diagnosis, and then bioglue is used to embolize UAVM. In cases of high flow UVM or uterine arteriovenous fistula, coils may be used in combination with other embolic agent. Another effective endovascular approach is balloon occluded retrograde transvenous obliteration. UAVM reduction therapy is performed entirely through BRTO by injection of sclerosant agent. This is different pictures for embolization. The surgical treatment, also hysterectomy, is the definitive treatment for UAVM. It is no longer considered the first line of treatment and generally reserved for women who show failure in embolization therapy and have no desire to conserve their fertility. Open hysterectomy is considered an invasive procedure. So, with emergence of laparoscopic approach, hospital stay, patient morbidity, and mortality associated with hysterectomy has reduced significantly. Selective embolization before surgery can provide good control of UAVM. Gene therapy, as I mentioned, the congenital type is the arrest of embryogenic development of capillaries. The recently identified molecular pathway involved in the development of these potential lesions, inhibition factors, may improve the treatment problem. One proposed hypothesis is that endothelial dysfunction that produce AVM is caused by increased activity of the kinase MBAK1 and also known as MEK1. The MEK inhibitors are used in cancer and may have potential in application in AVM. So the inhibitory factor for these pathways may lead to inhibition of cell growth, cell proliferation, angiogenesis, and the growth of AVM. What is the complication of the UAVM? Treating UAVM with embolization has fewer complications than surgical management. Reported complication of embolization including infection, uterine ischemia, uterine necrosis, damage to other organ, and the possible problems in future pregnancy like placental abnormality. Hysterectomy is the most common gynecological procedure. It has its own complication. Another concern is ovarian failure. However, this can be avoided by isolating and ligating the uterine artery selectively, excluding the possibility of blocking the uterovarian communication arteries. Several studies have concluded that pregnancy is possible after uterine artery embolization. Follow-up of patient after treatment. The follow-up period is variable depending on the patient condition, type of treatment, fertility check, and so on. Patient can self-monitoring by clinical presentation for bleeding status, menstrual cycle, and follow-up for any other unusual symptoms. The ultrasound is cost-effective imaging methods for surveillance and follow-up. CT and MRI are also needed for detailed evaluation in some cases. If symptoms persist and the disease recur, re-embolization or radical surgery should be considered. In conclusion, UAVM is a rare cause of uterine bleeding in reproductive age women, which can lead to a life-threatening condition. Ultrasound is an effective tool for screening and initial assessment when UAVM is suspected. The characteristics of UAVM are increased vascularity and dilated blood vessels throughout the uterine muscle. Pelvic digital subtraction angiography is the present gold standard for the diagnosis of UAVM, which also help to determine the main feeding vessels in case of the consideration of embolization treatment. Conservative treatment, endovascular intervention, and surgery are choices for management up to the individual situation. And thank you for your attention.
Many thanks to Professor Abdou Said for